is the Bertarelli Foundation Professor and Chair of the Department of Otolaryngology, Head and Neck Surgery at Stanford University School of Medicine. She's a Harvard-trained ear and skull-based surgeon and a Massachusetts Institute of Technology-trained auditory neuroscientist. Her clinical focus is obviously otology and neurotology, and she previously served as the chief of the Division of the Otology and Neurotology at Mass Eye and Ear. In addition to her clinical and administrative duties, she directs a basic science lab which focuses on improving diagnostics and therapeutics for sensorineural hearing loss. And she has initiated and led several successful cross-departmental, national, and international collaborations to develop and deploy novel molecular diagnostics and therapeutics for hearing loss and otologic diseases in general, while educating the next generation of leaders in surgery and scientists. So really looking forward to her talk today. For those of you who haven't seen her TED Talk, you should probably do that too afterwards. So with pleasure, I introduce Dr. Tina Stankovic. Thank you.
Thank you for the kind introduction, Vikas, and I'm indeed delighted to have an opportunity to tell you about our ongoing research to enable precision diagnosis and therapy of human sensorineural hearing loss. As a way of disclosure, I'd like to acknowledge the funding support for our research that has come from the government, several foundations, as well as grateful patients and families. I would like to start by reminding us how lucky we are to be in the field of otolaryngology, head and neck surgery, because it has had an illustrious past and I think an even brighter future. It turns out that the world's very first named physician, Sekhet Enenak, was a rhinologist, because in the ancient Egyptian writings, he's referred to as the healer of the king's nostrils. And then it was Hippocrates and several other prominent physicians throughout the Middle Ages who described the anatomical structures that we're so familiar with and that we operate on. The progress in all of medicine was galvanized by the first public demonstration of general anesthesia, which occurred 176 years ago at Massachusetts General Hospital. And as you can see in this historic painting, the surgeons performed a procedure in the neck, which is our turf. Otolaryngologists were quick to adopt anesthesia and other technological advances, including optics, to accelerate progress in our field. And in fact, it was a Scottish surgeon, McIntyre, who was the first to incorporate incandescent bulb, a miniature light bulb, into an endoscope so that he could better examine the larynx. And this occurred only 3 years after Edison patented incandescent light. A few years later, it was Barany who won Nobel Prize for his discovery of the vestibular apparatus. Optics continued to illuminate our field when two Swedish surgeons were the first to introduce a microscope into the operating room. And of course, this invention propelled progress in all of surgery, from neurosurgery to microvascular surgery. And then it was a physicist, Hopkins, who invented the Hopkins rod, which provided a much more intense light than ever available before and a much higher resolution. And again, our field was quick to adopt it, and the Hopkins rod is now, of course, a familiar name, which really propelled progress in all of endoscopic sinus surgery and laryngoscopy. Hopkins was nominated for a Nobel Prize twice for his seminal contributions to the development of medical devices. And then it was another physicist, von Beckerschi, who some 60 years ago won Nobel Prize for his discovery of how the cochlea works, and in particular, he discovered the traveling wave and the place frequency map. That was readily adopted by engineers to enable the development of a multi-channel cochlear implant. And in fact, seminal contributions were made at Stanford by Blair Simmons, who was the first to implant a multi-channel, multi-electrode cochlear implant in collaboration with Stanford engineers, including a then chair of electrical engineering, Bob White. And some 9 years ago, it was Clark, Hochmeyer, and Wilson who won Lesker Prize for their seminal contributions to the development of the modern cochlear implant. And of course, we now know that cochlear implant is the most successful neural prosthesis with more cochlear implantees than users of all other neural prostheses combined. This slide illustrates and reminds us that while the 20th century was all about physics and the 19th century was all about chemistry, it's becoming clear that the 21st century is turning to be all about biology. And when looking at these trailblazing discoveries that our colleagues adopted and helped advance science and technology in their times, it is relevant to reflect on the distinguished career of Dr. Brian Neel. He was born in Rochester, Minnesota in 1939. He graduated from Cornell with an undergraduate degree and then pursued medical school at the State University of New York in Brooklyn. After spending a year in general surgical training at the University of Minnesota, he spent 2 years as a clinical associate at the National Cancer Institute surgery branch. He then went to Mayo Clinic, where he completed his residency in otolaryngology head and neck surgery and also completed his PhD. He stayed at Mayo, where he moved through the ranks to become professor and chair of the department, and as a surgeon scientist, he made several seminal contributions to our field, including enlightening the role of tumor immunology, cryosurgery for cancer, as well as hormone receptors in head and neck cancer, among many other discoveries. As an educator, he developed clinical investigative program for residents. So now when reflecting on his career, it is instructive to consider what it takes to have optimal experience. And this was studied extensively by a late psychologist, Csikszentmihalyi, who termed the coin flow. And to understand what he meant, we can look at this diagram, and on the vertical axis, we see the challenge level, and on the horizontal axis, we see the skill level. He defined flow as the state of optimal experience where we experience full immersion and an energized focus. And you can see that this state of flow requires high skill level and high challenge level. And it stands in contrast to anxiety, which is associated with a high challenge level but a low skill level, or boredom, which is associated with a low challenge level. And he studied people in all professions and found that anyone can be in the state of flow. He studied people who work on the assembly line, professional athletes, performers, businessmen, physicians, writers, and interestingly found that one profession really stands out because people are in flow most common. And that profession is surgery. And in particular, surgeon scientists were found to be in flow most commonly. And that makes sense because all of us know that what we have to deal with on a daily basis requires a high skill level while addressing challenging situations. So then we could say that all of us in surgery really epitomize the concept of convergence, where convergence describes an approach to solving complex problems that address deep societal and medical needs, and in the process integrate methodologies, knowledge, as well as expertise from many different fields, with the aim of forming novel frameworks to catalyze discovery and innovation. So today I'll tell you how we have embraced this concept of convergence to solve some of the most challenging problems in the auditory field. And before I do that, I will just put things in context by reminding us that hearing loss is the most common sensory deficit across the globe, and it currently affects 1.5 billion people. It turns out that 1 billion of these people are disabled by this hearing loss, where disabling hearing loss is defined as having audiometric threshold shifts of 40 decibel or more. Alarmingly, hearing loss is on the rise because it's projected that more than 2.5 billion people will be affected by hearing loss by 2050. And the cost of unaddressed hearing loss is the astronomical $980 billion annually. So given these staggering statistics, what our research has focused on is addressing the unmet medical needs of the hearing impaired. And in particular, I'll show you on 4 research vignettes what problems we are focusing on. It's the need to see cells in a living human inner ear. It's the need for cellular models of human hearing loss, the need for pharmacological and biological therapies for hearing loss, as well as the need for better devices for hearing restoration. So now let me start with the first need, which is the need for high-level intracochlear imaging. This microcomputed tomography scan of the human cochlea reminds us that the cochlea is a small organ located in the base of the skull, surrounded by bone, while itself being encased in the densest bone in the body. So for these reasons, state-of-the-art clinical imaging of the inner ear today does not provide cellular level resolution. On the top, you see a computed tomography scan where, of course, the white color represents the bone that surrounds the inner ear. And at the bottom, you see a magnetic resonance imaging scan where fluid-filled spaces are shown as bright on this heavily T2 weighted image. But we do need to see what's going on. And to enable that technology, we collaborate with Gary Tierney, who is at Massachusetts General Hospital, and we are using micro-optical coherence tomography, which is a high-resolution successor to optical coherence tomography, which is routinely used in the diagnosis of retinal disorders. So in this experiment, we removed the inner ear from a guinea pig. We made a small cochleostomy and then imaged intracochlear structures through that cochleostomy. And here you recognize the familiar structures, and in particular, you see the vibrating basilar membrane, the organ of Corti that's located on top of it, as well as the scala tympani. If we now focus on this triangular space, which is called the space of Newell, we can actually fly through this space for several hundred microns. And if you focus at the bottom of that triangular space, you'll see white tubular structures. You see a couple of them are just coming in view now. And if we now take a digital cut at the level of the basilar membrane, then we'll appreciate these tubular structures, and we can recognize them as nerve fiber bundles. And based on their caliber and radial direction, we know that they are headed to innervate outer hair cells to modify their function and hence the dynamic range of hearing. The next question was, okay, now that we know that this technology can tell us about the normal anatomy, can it detect pathology? To answer that question, we did experiments in mice, which we exposed to loud noise levels, the equivalent of attending a loud rock concert for a couple of hours. And then you see a striking difference between the organ of Corti on the top and its complete absence at the bottom, because the organ of Corti was entirely wiped out. Well, knowing this would be critically important for our patients, because it turns out that gene therapy would not work for the scenario shown at the bottom, because if you're using gene therapy that's based on transdifferentiating supporting cells to hair cells, or on fixing function of any cell within the organ of Corti, there are no cells that would receive that therapy. So the therapy would not work. And motivated by that clinical need, we are now developing a miniature endoscope that we can insert into the human inner ear through the round window in a similar fashion that we insert cochlear implants. We have built a prototype, and the images obtained with it are shown here, where the diameter of the probe, you can see the probe here, which is sitting in the scala tympani, and these experiments were done in human cadavers, and it's 800 microns in diameter. We can see the organ of Corti and additional microanatomy within the human inner ear. More importantly, we can see the difference between the presence, shown on the left, and the absence of the organ of Corti, shown on the right. And again, that has dramatic implications in terms of treatment options. And the histological equivalents of these images obtained with micro-optical coherence tomography are shown at the bottom. So I think I've convinced you by now that it's really important that we know what is going on so that we can develop rational therapies. And in fact, it turns out that genetic hearing loss is incredibly homogeneous, with already more than 200 deafness-causing genes identified in humans. But alarmingly, for only 20 of these genes is the cochlear histopathology known. And that's because today, the only source of information about the cellular basis of human hearing loss comes from studying autopsy specimens when people die of unrelated causes and donate their ears for study. However, what we have learned from animal models is that there is progressive cochlear degeneration in genetic deafness. And I'm showing you an example here of a mouse that carries a human deafness-causing mutation in a gene encoding for connexin 26. And of course, we know that mutations in connexin 26 are the most common causes of non-syndromic sensory neural hearing loss in many patient populations. You can appreciate a dramatic difference between the appearance of the inner ear on the left, which is when the mouse was 2 weeks old, the equivalent of a human newborn, and at 7 weeks of age, which is the equivalent of an adolescent. Because by adolescence, the organ of Corti is gone and spiral ganglion neurons are decimated. That means that even if you know the genetic cause of hearing loss, you still don't know what that ear looks like, and the therapies that you prescribe will vary dramatically depending on when you see that patient along the degenerative timeline. Because if you see them as a newborn or a 1-year-old, a simple gene replacement therapy may work because the cells are there. But if you see them as an adolescent or adult, it may not work anymore because cells are not there. And to enable gene therapy for human hearing loss, we have shown that there is a way for efficiently delivering genes to the non-human primate. And this is a collaborative work with Mike McKenna and Luc Vanderberg, who were then at Massachusetts Eye and Ear and now are at AAO-HNS. And what I'm showing you is monkey cochlear explants, so surface preparations of the monkey inner ear, and at the bottom 2 rows, you can see the green color, which shows that these hair cells, and in particular inner hair cells, were very effectively transduced by this viral vector. It's called ANC80, and it's a synthetically made adeno-associated virus. And you can see that it's far superior to another viral vector that we tried, which is called AAV1, which stands for adeno-associated vector 1, because you see very few green cells there. Importantly, we see effective transduction along the length of the cochlea. What's very interesting and highly relevant is that in addition to gene therapy being relevant for treating dysfunctional sensory and neural elements in the inner ear, it's also highly relevant for treating the surrounding OD capsule. Because we know that there are diseases that affect the OD capsule, such as cochlear otosclerosis or Paget's disease, that cause sensory neural hearing loss. And in fact, in a recent study done in collaboration with Finnish investigators led by Arno Palotie, we have completed meta-analysis of genome-wide association studies of otosclerosis in 3 large biobanks, namely the Finnish, Estonian, and the UK biobanks. And we have identified 27 novel risk loci for otosclerosis, with all these genes that are listed being very closely spatially linked to the variants associated with increased risk for otosclerosis. What I find interesting about this slide is that there are a couple of genes that we had previously described in both the human and the mouse inner ear. And in particular, this gene called TGF-beta1, which stands for transforming growth factor beta. Its close cousin called TGF-beta induced, is present in human paralymph. We found it by collecting paralymph from patients undergoing cochlear implantation and testing it using proteomics. And then we identified that this gene is expressed in spiral ganglion neurons as well as within the organ of Corti. Another gene on this list is TNF-SF11, which is also known as rank ligand. And we recently published that rank ligand is expressed in spiral ganglion neurons in a developmentally dependent fashion. So this is where convergence again comes together. And it's really very reassuring that the data are painting a unifying picture. Namely, we are seeing a bidirectional flow of regulation between sensory neural elements within the inner ear and the bone that surrounds it. And that makes sense because these structures are next to each other, and it also makes sense that neurons would control the surrounding bone and the bone would talk back to neurons because most of these neurons have to pass through bony foramina to reach their distant targets. So with that, I will now move to the second vignette, which illustrates the need for human cellular models of hearing loss. And this is because 90% of drugs fail, and the vast majority of them fail for safety reasons, and this is after they have shown efficacy in animal models. So this is a very costly problem because it takes many years, on average 10 years, and costs in excess of $2.5 billion to discover that a drug doesn't work. So that's why we have decided to develop human models of human hearing loss, where we start with patient's skin or blood, and then we can convert these cells into induced pluripotent stem cells. And by now, this is routine. Yamanaka, who discovered how to do that, won Nobel Prize for that discovery. And then we can differentiate these cells into cells of the inner ear that we can grow either in 2 dimensions in a petri dish, or we can let them self-assemble into 3-dimensional organoids. And then we can use these cells for multiple downstream applications, ranging from disease mechanisms to various functional assays, to drug testing, and even cellular therapy, such as cellular transplantation. I will show you an example of how we have used these models to understand the mechanisms underlying audiovestibular symptoms that we sometimes see in patients affected by COVID-19. During the very first wave of the COVID pandemic, we saw 10 patients across 5 different institutions in the United States, most of them from Rutgers, who experienced sensory neural hearing loss in the setting of COVID diagnosis based on SARS-CoV-2 testing. It turns out that 90% of these patients also experienced tinnitus, and 60% of them experienced vertigo. All of them underwent contrast-enhanced MRI imaging, And in one of them, we saw clear enhancement of the vestibule, as well as the facial nerve and the geniculate ganglion, and some enhancement of the audiovestibular nerve bundle. This finding now begs the question of how does the virus do this? To answer that question, we first have to remind ourselves of how SARS-CoV-2 breaks into human cells. It's a coronavirus, so it has these spikes on its surface, and the spike binds to a receptor on the recipient cell, and that receptor is called ACE2, which stands for angiotensin converting enzyme. And then there are two enzymes called furin and TMPRSS2, which cleave the spike and allow fusion of the viral membrane with the host cell membrane and release of the viral cargo into the cell. So what we did is we looked for expression of these three proteins, namely ACE2, furin, and TMPRSS2 in human inner ear cells. And we got these cells from induced pluripotent stem cells, which are shown in the first row, and then we differentiated these cells into either otic prosensory cells, shown in the second row, or Schwann cell progenitors, shown in the third row. And you can see that all three cell types express the proteins required for viral entry into the cells, with the differentiated cells expressing them at higher levels than the induced pluripotent stem cells. In addition, and in collaboration with Lee Gerke at MIT, we then exposed these human inner ear cells to the virus, and we saw that it readily infected the cells, as shown by immunostaining for viral protein called nucleoprotein, shown in red, as well as the double-stranded RNA, shown in green. The next step was to now look at expression of these proteins of interest in human inner ear organoids. And this is a picture of an organoid that's lined by hair cells, and you see other cell types shown in blue and nerve fibers shown in green. Strikingly, the SARS-CoV-2 receptor ACE2, shown in pink, is abundantly expressed in human inner ear cells. And when we expose these human inner ear organoids to the virus, we see that it readily infects hair cells more than any other cell type. That is highly clinically relevant because in our patients who underwent otoacoustic emission testing, all had either absent or reduced otoacoustic emissions consistent with hair cell injury. So you could say, well, this is all done in cells derived from stem cells, but how about the real deal? How about the adult human inner ear tissue? I told you already that it's not easy to get hold of it. However, we do occasionally get it when we perform indicated surgeries, such as translabyrinthine vestibular schwannoma resection or labyrinthectomy for intractable Meniere's disease, where we literally drill through the vestibular part of the inner ear. And in that case, we actually saved these little pieces of the vestibular epithelium. And I'm showing them here, and we can clearly see hair cells, which are shown in magenta, as well as nerve fibers shown in green. And when we now look for the expression of the three proteins of interest in these adult human inner ear tissues, we see abundant colocalization of the three proteins of interest in the apical surfaces of hair cells, and to a much lesser degree in Schwann cells or neurites. And when we now culture these human inner ear tissues in a dish, we can keep them growing for several days and then expose them to the virus. We again see by now the familiar picture, namely the virus preferentially infects human inner ear cells. So how does the virus get there? We don't know at this point, but there are several hypothesized mechanisms. One is they could get there through the eustachian tube, and via the eustachian tube, they can get into the middle ear, and from there, via round and oval windows, they can enter the inner ear. Or they can get there through olfactory foramina that allows the virus to enter into the intracranial space, from which it can seed multiple nerves, as we have seen in the patient I showed you, or it can get there through the endolymphatic sac, and in some of our patients we have seen symptoms consistent with endolymphatic hydrops, or it can get there hematogenously through the labyrinthine artery. So with that, I will now move to the third vignette, which illustrates how we are approaching drug repurposing. Because the idea is to use drugs that are already FDA approved for some other indications and then repurpose them for sensory neural hearing loss. And I'm focusing on a particular disease, namely vestibular schwannoma, which is an important cause of human hearing loss, and it gives us a rare opportunity to get hold of human inner ear tissue that's relevant for hearing. In this picture, I'm contrasting two patients. On the left, it's a patient with a small intracanalicular vestibular schwannoma, and on the right, it's a patient of the same age and sex with a larger tumor and a similar extent of the tumor within the internal auditory canal. However, they caused a vastly different degree of hearing loss. For the patient on the left, they had a dramatic drop in their pure tone average and an even more dramatic drop in their ability to understand words with the word recognition score of only 8%. By contrast, the patient on the right had relatively mild hearing loss and no effect on word recognition scores. Well, you could say that this is anecdotal. However, we have all seen multiple examples like this, and more recently, we completed the analysis of nearly 500 patients and have grouped them into 4 categories based on Kuh's classification, namely whether the tumor is entirely located within the internal auditory canal, or if it extrudes out of it a little bit, or if it fills the cerebellopontine angle and touches the brainstem, or if it compresses the brainstem. And when we now look at these nearly 500 patients, we find no correlation between tumor size and the severity of hearing loss at the time of vestibular schwannoma diagnosis when analyzed using either pure tone average or word recognition scores. So that begs the question of how are these tumors then causing hearing loss? Over the last 10 years, we have developed the story and provided evidence that these tumors can secrete molecules that are ototoxic or neurotoxic and hence can cause direct cochlear damage. We have also shown that pharmacologic or molecular blockade of these factors can be therapeutic. Together, these data have motivated our ongoing prospective randomized placebo-controlled phase 2 clinical trial of aspirin for vestibular schwannoma that currently involves 8 institutions across the United States. At this point, we are not recommending that people just start taking aspirin on their own. However, we strongly encourage them to participate in our study so that we can figure out whether it works or not. Well, building on this theme of the importance of the microenvironment of the tumor in contributing towards sensory neural hearing loss, we were intrigued by a finding published 10 years ago that the degree of fibrosis within tumors correlates with the severity of hearing loss. This observation was done in a large cohort of patients, over 200 patients, and we were then intrigued in the possibility that anti-fibrosis drugs may be relevant for vestibular schwannoma. And one anti-fibrosis drug that we zoomed in on is called losartan. Of course, we all know that losartan is an antihypertensive. It's an angiotensin receptor blocker, but it's also known to importantly inhibit fibrosis. And our first step, and this is the work done in collaboration with Lei Shu at Massachusetts General Hospital, our first step is to look for expression of angiotensin receptor in human vestibular schwannoma tissue, and we found abundant expression, as shown on the far right. And we also found abundant expression of angiotensinogen, as well as a couple of other highly relevant extracellular matrix proteins, namely the hyaluronic acid binding protein, as well as collagen 1. The next step was to ask, well, could losartan be therapeutic then? And to do that, we used a mouse model of vestibular schwannoma that we developed. And this entails stereotactically placing tumor cells into the cerebellopontine angle. And these tumor cells are transfected with a reporter, which is a fluorescent secreted reporter called Gaussian luciferase. And that allows us to measure very precisely how fast the tumor grows by simply sampling blood from these mice. And you need only 100 tumor cells to detect the presence in blood. Using this mouse model, we then treated mice with losartan and compared that to mice that were not treated and to mice that received sham surgery and had no tumors. And strikingly, we found that mice that received losartan had no tumor-induced hearing loss. They still formed tumors, but there was no hearing loss associated with the tumor. And we see that both in terms of otoacoustic emission testing, shown on the left, and ABR testing, shown on the right. What is the mechanism? Well, it's multifactorial, like most things. It involves reduction of neuronal edema, as well as reduction of the inflammatory response. We decided to zoom in on one particular pro-inflammatory molecule called interleukin-6 because it's a close cousin of tumor necrosis factor alpha, and we had previously shown association of TNF-alpha with the severity of hearing loss due to the tumor. And we find that now in human tissues, which once we collect them from surgery, then we incubate them in culture media, and now we have tumor conditioned media. And if we measure concentrations of interleukin-6 in these human tumor conditioned media, we find that it associates with reduced viability of cochlear sensory cells and neurons when these secretions are applied to explants. Well, so that now begs the question, do people who take losartan have less tumor-induced hearing loss than people who take other antihypertensives that are not in the angiotensin receptor blocker group? And the answer is yes, based on this pilot retrospective analysis, where we find that people who take losartan and related angiotensin receptor blockers, shown in red in these Kaplan-Meier curves, have no progression of their hearing loss compared to patients who take other or no antihypertensives. This finding has now motivated the ongoing design of a prospective study to determine whether losartan can prevent tumor-induced hearing loss in vestibular schwannoma patients. So future clinical trials should involve looking at circulating biomarkers in addition to things that we normally look at, such as MRIs and audiometric profiles. And we have previously shown that one of these tumor-secreted molecules called MMP14, which stands for matrix metalloprotease 14, its levels in blood of patients with vestibular schwannoma correlate with the severity of tumor-induced hearing loss. Of course, this is not the only molecule, but it's the beginning. And it would be highly relevant to also perform liquid biopsy of the inner ear, because these tumor-secreted factors should be concentrated in the inner ear. And to enable future routine liquid biopsy of the human inner ear, we initially described the proteome of human paralymph. We also developed a very simple device, which is based on a microneedle that's beveled and has a step-off to allow controlled and reliable cochlear liquid biopsy. And then we show that we can see diagnostically relevant differences in molecular biomarkers of hearing loss in as little as half a microliter of inner ear fluid. That's highly relevant in terms of translational implications because the human inner ear doesn't have a lot of fluid. The volume of human paralymph is about 150 microliters, and here we're taking less than 1%, which really shouldn't affect hearing in any way, which opens the future possibility of routine and repeated liquid biopsy of the human inner ear to precisely tailor treatments. So now this brings me to the fourth and the final vignette, which is focused on novel devices. We have already mentioned that cochlear implants are the most successful neural prosthesis out there. However, they do have limitations. And a couple of these limitations include imperfect ability of cochlear implantees to understand words and their problems with music perception. One of the reasons for these difficulties is the fact that there is a spread of current from any one electrode. In fact, we sometimes end up turning off some of these electrodes to reduce this interference and allow people to hear better. But it's a problem if we keep turning off these electrodes because these existing cochlear implants have up to about 24 of electrodes, and yet there are 30,000 neurons in the auditory nerve. So ideally, we would like to have more precise and focal stimulation. And some people think that magnetic stimulation provides that. In fact, there is a number of people in neuroscience and neurology studying the efficacy of magnetic stimulation in all parts of the central nervous system, including the brain. And in collaboration with Shelley Freed at Massachusetts General Hospital, we decided to test the feasibility of magnetic stimulation of the cochlea. So the idea is that this microcoil depicted here uses the principle of induction to induce current, which is very localized. Now, this is how the transformer works. And we're all familiar with transformers because all of us have them close to our homes. However, this is a much harder problem because the type of information, the signal that needs to be transmitted is much more complex, and the transformer needs to be bathed in fluid that itself is complex. So our approach was to test this in mice where we placed a microcoil either in the base of the cochlea or the apex of the cochlea, and then we recorded the spread of activation via a multi-electrode array that we placed in the inferior colliculus. And I'm now showing you examples of these recordings, first from an animal that was acoustically stimulated, where I'm plotting sound intensity as a function of the recording site. And you see these so-called spatial tuning curves because you see that they are sharply tuned in response to different tones of different frequencies that were presented to the mouse ear. Now, if we stimulate magnetically, shown on the top, or electrically, shown at the bottom, after we deafen these animals, we see that magnetic stimulation provides sharper tuning. We can now quantify that by plotting either spatial spread, shown in the first row, or spectral spread, shown at the bottom row, for three types of stimulation, namely acoustic stimulation, shown in black, or magnetic stimulation, shown in red, or electric stimulation, shown in blue. So overall, you see that the extent of activation with microcoils is about 60% narrower than that produced by electric stimulation, and overall is very similar to the spread arising from acoustic stimulation. If we now plot response magnitude as a function of stimulus amplitude, we see that magnetic stimulation provides a broader dynamic range because electric stimulation saturates quickly. If we now plot that across all animals that we analyzed, we see that in general, the dynamic range of coils is 3 times larger than that of electrodes. So taken together, these data demonstrate the feasibility of magnetic stimulation of the cochlea and certainly open future possibilities for device development. The path forward will be complex and lengthy, but I think it's worth it nonetheless. So in summary, today I have shown you our convergence approach towards enabling personalized diagnosis and therapy of hearing loss, and I've illustrated on 4 examples how we do that. And our approach is in line with the Stanford Medicine's focus on precision health, which aims to be predictive, proactive, preemptive, personalized, and patient-centered. I would like to thank people in my lab who have contributed to the work I've described, as well as the entire Department of Otolaryngology, Head and Neck Surgery at Stanford, where the spirit of curiosity, innovation, discovery, and camaraderie abounds. I would also like to thank the American Academy of Otolaryngology, Head and Neck Surgery, where together, using this convergent approach, we can restore and maintain the health of our patients. And finally, I'd like to thank my family, whose unconditional love fuels me. With that, I am ready for questions. Thank you. Thank you, thank you. Yes.
The graph of the magnetic implant versus electrical, what was the time frame? How long after implantation was the magnetic graph generated? And has there been one done over time?
We can repeat the questions. Go ahead, actually.
Sure. So the question was, what's the period of time over which the magnetic versus the versus electric cochlear implantation was performed? These were proof of feasibility experiments. So all we did was put in a microcoil acutely. We don't have a device that we can implant chronically. What we do have is 2 different modes of deafening, which is either acute by injecting distilled water into the inner ear, which causes massive osmotic shock as well as mechanical trauma, or chronic deafening, where we have used gentamicin. So in both of these models of deafening, we see the same effect, demonstrating apparent superiority of magnetic over electric stimulation, but experiments that you are asking about remain to be done. Yes? This is a great question. What are the implications of a magnetic cochlear implant for future MRI imaging? This is a great question. I think it's really, really early because we don't even have a device. All of these are pilot experiments that now certainly motivate the development of a device. There are also some very practical limitations. For example, power requirements for magnetic cochlear implant are much higher than for an electric cochlear implant. And maybe future devices will include hybrid electric and magnetic stimulation. And we already know that even people with the existing non-MRI compatible cochlear implants can still undergo MRI imaging if we wrap their head with low power magnets. So I think your question is excellent, and it's certainly worth thinking about as we envision the future. But at this point, our data are really at a pilot level. Yes? I didn't hear that completely. Oh, should we be putting our vestibular schwannoma patients on losartan? I would say not yet, because we really hope to do the study and find out whether it works, because that's the only way to really find out. And in our field, unfortunately, there is a relative paucity of prospective randomized placebo-controlled studies, which are the norm in all other branches of medicine. But in the meantime, if people are already on losartan or a related angiotensin receptor blocker, and now their primary care physician is considering switching them to something else, then I do encourage them to continue on losartan if medically indicated and if they have a vestibular schwannoma. But at this point, I wouldn't just start treating everyone with losartan. Yes? Sorry, I'm hearing two questions, one at a time. Yes. Oh, so the question is why magnetic and not optical? Is that the question? Yes, it's an excellent question. And in general, it's excellent to have a portfolio of options. We know from all of medicine in general that one size doesn't fit all. And it's when we have a variety of options that we can tailor therapies specifically for a given person. Optical stimulation is awesome in that it also provides really much finer spatial resolution. However, it requires an extra step, which is making neurons that normally do not respond to light sensitive to light. So it actually requires a step of gene therapy by transducing them with channel rhodopsin and related proteins, and then putting in an optical cochlear implant based on optrodes as opposed to electrodes. And that is certainly a very attractive option for some patients. And if you think about the future where we may be using gene therapy to restore hearing biologically, then you want to leave that option for gene therapy targeting a specific gene as opposed to making only spiral ganglion neurons sensitive to light. And gene therapy, it's not necessarily a gift that keeps on giving. Theoretically speaking, you can give it multiple times because the body mounts an immune response to the viral vector that you are using to deliver the therapy. And in fact, some of the failures of gene therapy for other diseases had to do with the fact that people were actually immune to the vector and they weren't even tested for the levels of antibodies to adeno-associated virus or adenovirus. And so that's something to think about. We basically don't want to burn bridges for patients, and I think it's very exciting to have multiple options, including optogenetics, magnetic stimulation, electric stimulation, and certainly biological and regenerative therapies. Now there was another question in the back. Yes. Yes.
And also, at the ANS, I don't know if you saw that presentation about imaging where they were showing how actually the gadolinium is leaking out of when they image these people many hours later. Mm-hmm. They're actually seeing this visual connection between the two, separate from the tumor and the inner ear structures. And I was wondering if you've seen any imaging correlates to the neurologic.
That's a great question. Thank you, Dr. Cassetti. The first question has to be about liquid biopsy and widespread adoption in our field. I think it's coming, and I've shown you an example of one of the molecules. We are now analyzing many more molecules. We're not the only ones, and that's great. It's great. The progress occurs when there are multiple people working on the same problem, because then there is a momentum. There is a critical mass to get things done. So I think we will start doing things more precisely. One of the problems is that in the past we were doing things just because we were familiar with them, such as CBC or checking a few hormone levels. But now we are talking about much more precise molecular biomarkers that are tumor specific and they are guided by big data. For example, we identified MMP14 by overlapping the transcriptome of vestibular schwannoma, which means all of the genes dysregulated in vestibular schwannoma, with the degradome database. And the degradome, that's a collection of all known proteases. So it was really a big data approach that identified one molecule that we would not have identified otherwise. So I think that's really an exciting area. I think we'll be doing a lot more liquid biopsy in our field for all sorts of diseases, and whether it's circulating biomarkers in blood or paralymph or any other fluid, that is exciting. And the other question is, oh, the imaging, yes. Is there a correlation between what we see molecularly with imaging? Yes, that study was actually done in the UK at the University of Manchester, where they imaged people with vestibular schwannoma using a PET tracer that is specific for inflammation. And in fact, it was the first in vivo demonstration in people of enhanced inflammation in vestibular schwannoma. And it's looking at specific markers, again, guided by better understanding of the underlying molecular and genetic biology to develop precise targeting markers. Thank you. Yes. The question is, what are the challenges with magnetic stimulation? And you mentioned transcranial magnetic stimulation, which of course is external. Here we are talking about placement of a coil within the cochlea, so that right away is different because the fields are different. And also, interestingly, transcranial magnetic stimulation actually generates a very loud noise. It's even louder than some of the MRIs. So it's a scale difference and power difference and application difference. But all of these are very interesting to consider. In terms of extracranial stimulation, it's always about precision. You have seen how tiny these structures are. So the closer you bring the coil to the structure you're interested in, the more likely you are to stimulate what you really aim to stimulate. The farther away you are, the broader the field. Oh, the question is it the exons or is it the neuronal cell bodies? We would love to target just exons, but of course in humans, it's a spectrum of diseases that, because spiral ganglion neurons, they are bipolar neurons. They have the axon that goes to the cochlea, the peripheral axon that goes to hair cells, and the central axon that goes to the cochlear nucleus. In people, there's all sorts of pathology. They can only have missing the synapse between hair cells and neurons. They can have the unmyelinated portion of the peripheral axon gone. They can have the entire peripheral axon gone. As long as they have the neuronal cell body, they are stimulatable. In terms of electrical stimulation, we know that as long as the neuronal cell body is there, they are excitable. To really answer your question precisely, we need to do modeling, and that's in progress. Yes?
Great presentation.
Thank
My
you.
question is kind of related to the question over here about the physiology and the protective effect of losartan. Do you envision that this is a fibrosis effect, in which case I would wonder if it would also correlate with ease of dissection at the time of surgery? Or is there potentially another aspect of that that could be neuroprotective more acutely for patients that are under
That's an excellent question. So the question is, would it make sense to put people on losartan prior to surgery to facilitate surgery, to make the tumor less sticky? I think we should do a study, and a prospective, well-designed study. In the meantime, what I can tell you is that anti-fibrotic effects of losartan have been used to prolong life expectancy in people with malignant cancers. So for example, now for pancreatic cancer, for ovarian cancer, losartan is used and actually dramatically improves the quality of life. You know that in these diseases, even if you prolong people's lives for a few months, that's a winner. And losartan is proving to do that, and the main mechanism in those scenarios is anti-fibrotic. In our model, it was multiple mechanisms. One was anti-fibrotic. The other one is actually it reduced edema in the nerve and in the brain. The third was that it reduced inflammation. And the fourth one is that it actually normalized vasculature. And we can quantify the ramification of these blood vessels, and they look very abnormal in tumors compared to non-tumorous tissue. And we can quantify both their ramification and the number. So basically, it acts via multiple mechanisms. And I think you are proposing a really intriguing study and highly relevant, that if we can simplify surgery, go for it. In the meantime, we did find that this MMP-14 molecule, that its levels in people's blood correlated with the difficulty of surgical resection. And that makes sense because MMP-14, it's normally degrades the extracellular matrix, and it's produced by cancer cells, and it actually allows them to metastasize. Of course, schwannoma is not a cancer, it's a tumor, but some are more aggressive than others, sort of locally behaving like a cancer. And basically, that appears to be one of the biomarkers of that severity. So could losartan affect circulating MMP-14 levels, and could that correlate with the difficulty of surgical resection? Let's do the study.
Thank you, everyone, for, oh, one more question. Oh, okay. Well,
I wanted to ask about AAV. If you think that there is a better AAV that could target low frequency and high frequency, and why are AAV mainly targeting low frequency more than high frequency?
So the question is, are there other viral vectors that could be used for gene transfer? And absolutely, AAO-HNS is one of them. The reason that we pursued it is because that it was rationally designed. I just mentioned the problem with immunity, and we don't want to have people immune to the therapy that you're about to give them. So the idea was to develop a new adeno-associated viral vector, which our body hasn't seen before. But looking at evolution and then using rational design, that's how AAO-HNS was developed. But in the meantime, multiple other new synthetic vectors have been developed, and some are not synthetic. And they are showing efficacy in various small and large animal models. Like anything, again, it's good to have a portfolio of options and use whatever is relevant for a given individual.
So just on the behalf of the Academy, I wanted to thank Dr. Stankovic for a wonderful lecture, really summing up a tremendous amount of work in a really concise and a way that even a lowly head and neck surgeon like me could follow. So thank you so much as a token of our appreciation.